Hi guys, welcome to some DDU practice for the Vivas for this year. Few things to update you on, and I do hope you're going to receive communication from the ASUM soon. There's a couple of new things that are coming out this year. So first of all, with a format, you've obviously got the written exam that was done with your supervisor. ASUM are talking about making that so it's online with computers, so that you can type rather than write out. I'm pretty sure you can have an option if you don't want to type. And it is on a special kind of format, which is a bit like Word. So just to bear in mind that's the first thing. The second thing is that I'd ask them to consider adding in writing a conclusion for a case. And they've taken it in. I'm sorry, it's a little bit in the last minute, both for the emergency and for the DDU exam. So instead of having 10 written questions of 15 minutes each with 10 minutes of reading time, we're going to flick that round to have 9 written questions, no reading time. So you're straight into the exam. And then you've got 25 minutes for a case review. So I've put together a semi-full case. It's probably only about maybe 20, 25 slides rather than, the normal 40 or 50 or something. And you've got to write a conclusion at the end. So you don't have to write a full report. It's just a conclusion. But you get 25 minutes to do that final piece. Again, cumulative scores. I think we'll probably be marking it out of 15. So it normally comes to the same way that we've done before. So it's still cumulative scores, but it gives the examiners a chance to see how you write a conclusion. Cool. And then
is that is it transthoracic purely, or
can be either anything on the syllabus is what it can be. So it could be transthoracic, transesophageal, and or including some general ultrasound. So it can be anything on the scale. Chat's just joining. Do you mind if I repeat some of this? I'm really sorry because it's going to be highly relevant. Oh no, sorry, it doesn't be relevant. She doesn't need to do the. Sorry. So the Vivas are still, as far as I understand at the moment, all going to be online. You will be able to do it somewhere where you've got good internet access, and you will you'll be given the password. You'll open up the PowerPoint presentation. You will be in charge of the PowerPoint, and the examiners, there'll be 2 examiners at the other end, plus maybe 1 observer. Depends what group you're in, and then they will tell you when to move forward, and you've got a bit of time for faffing around in there, so it's not super rushed. And again, 40 minutes, 7 or 8 questions. You've got to complete the whole exam, and the examiner will take you through it. Jo.
With the written, if you're drawing diagrams, obviously you won't be able to do that on typing. Is that going to be?
Yeah, an interesting question. I think there are options for freehand. It's not going to be easy. I think drawing diagrams is going to be a bit challenging.
I have to get my words good then.
Yeah. So I think the big thing is obviously trying to have a look at this case, this conclusion that comes out of the case. I think it's a really good thing. I'm very supportive of this. I brought this up as a potential way to examine people because I think it's what we do it's more realistic than anything else, really. So yeah, let's do that. Cool. Do you want to do a few cases? Cool. Drew, you're not sitting this year, so I'm going to focus mainly on Joe and chat, and we'll go from there. Okay. All right. Joe, do you want to kick off?
Yep.
Oh, actually, yeah, this one's actually just maybe we'll just bounce through this one. So I'm going to steal a few. These cases were all stolen from my favorite journal, the Cardiovascular Imaging Case Reports case. This is from last year. And there's some great ones in here. This is one of my favorite articles that's come out from Case for a while, which talks about aortic regurgitation types. And why don't we just flick through a few of these as we go? But as we go, I want you to focus just like we do on mitral regurg. You probably heard me, Emma, Vishal, whoever's talked about these mitral regurg cases, when it's moderate or severe, it's all about mechanism, right? You have to explain why you're getting significant mitral regurg. And if you can do that before the examiner takes you there, that looks good. This article kind of highlighted the need to do that for aortic regurg as well, which I thought was quite nice. And they talk about these sort of 5 different ways of doing it. And that is whether you've got say, a sinotubular or aortic root dilation, or whether you've got annulus dilation. I'm kind of giving away, I've just copied and pasted the slide. I'm kind of giving away which one's which as we go through the cases. So you can either have the sinotubular or the aortic root dilation causing central aortic regurg. You could have annular dilation causing a central aortic regurg. You may have a perforation showing weird, I call it weird, calling some kind of eccentric, chaotic aortic regurgitation. You can have a prolapse causing opposite direction eccentric regurgitation, or restricted movement for whatever reason, such as thickening, again, causing eccentric regurgitation. So if you're seeing nasty regurg, maybe try and give it, they've labeled it as like 1A, B, C, or something like this in this journal. I'm not a huge fan of those classifications because they can be misconstrued and people can not want to appear silly if someone says, oh, this is clearly a 1C aortic regurg, and no one wants to ask what that means. So I prefer to be able to describe it as dilation, perforation, prolapse, or restriction. But as you're seeing each of these cases, maybe try and describe it like that, okay? And no ers, no ums, nice and clear, get to the meat of the stuff, and away we go. Good to go, Joe?
Yeah.
Cool. 65-year-old man, hypertension for investigation. I'll just take you back to the beginning. Ready to go?
Yes. So this is a parasternal long axis, and the most striking fixture is, are you flicking through?
Maybe just have a look through all of just look through all of them and then give me your conclusion towards the end.
Yeah. Okay, so it's a few pictures looking at the parasternal long axis, a focus view then on the aortic valve with colour, and then a short axis view of the en-face aortic valve. And the most striking feature is the dilated ascending aorta with a central jet of aortic regurg.
How would you assess the severity of the aortic regurg?
So looking at the colour flow Doppler, there is I would say it's at least moderate because there's a flow convergence zone. There's a vena contractor, which I'd need to pause to see the diameter of that and whether it was greater than 0.7. And then also the jet area in relation to the LV outflow tract. And it's filling the LV outflow tract. So it's at least, it's heading towards severe, moderate to severe.
What else would you need to do to be more confident about your severity of the aortic regurgitation assessment? What other views would you like?
So I'd want to have apical 5-chamber, sorry. So I can see the jet flowing through into the LV. I would like to run a continuous wave Doppler through that to look at the regurgitation jet to measure the pressure half time, and also then some pulse wave Doppler assessing the kind of outcomes of so looking at the whole heart then, so whether there's LV dilatation, what the LV function is like, and any of the complications associated with that. With this patient here with hypertension, I'd be worried about dissection. So I'd want to try and find out the etiology of the dilated ascending aorta. But some of that will depend on the chronicity. So I'll be able to find some chronic findings within the LV if it's been just an aneurysm that's developed over time.
Fair enough, that's good enough. So when we're asking about fine, everything you said was right in there. Don't forget AR, aortic flow reversal, descending aorta greater than 20 centimeters per second in the end diastolic value. I would have thought just with those questions that we love asking them, right? They're fairly, generic questions, asking about, how would you assess the valve? What other views do you need? Because we can't show you a full case in a Viva. And just try and get me the summary in there, just like we like summaries for, what's the cause of your patient's jaundice, just having that sort of surgical sieve, and in echo, just go 2D features. The 2D things that might point towards severe would be the enormous aortic root, color, You talk about flow convergence, vena contractor, LVOT height versus the the aortic regurg height versus the LVOT, continuous wave Doppler, values 200 versus 500 for severe and mild to moderate for the continuous wave Doppler, and pulse wave Doppler in the descending aorta if you can't get that, the aortic route. Just getting those through just in a little bit more speed is great, but that was all completely right. Nice one. Nice one. Okay, so chat, have a crack at this one.
So there is an eccentric jet of aortic regurgitation that looks to be associated with the right coronary cusp, which seems a little bit restricted in its movement, or the aortic root also appears to be dilated. The turbulence of the color jet seems fast, and there is an area of flow convergence, and there does appear to be a reasonable sized vena contractor there, but I'd have to slow it down and have a look and measure it.
What views would you like to determine the severity?
So the other things I would need to see in order to, if I just go through 2D continuous and go through those things. So the things I would want to see is the size of the LVOT, the size of the left ventricle, the size of the atria, and then the continuous wave profile through that regurgitant jet to see if it's a complete envelope, the shape of the envelope. And also flow reversal in the aorta, if it's demonstrated in accompaniment with the patient's tachycardia, blood pressure, and overall clinical status.
How do you tell the difference between acute and chronic regurgitation?
So acute regurgitation will usually be related to an acute pathology like a dissection or an endocarditis with a lesion on a valve or a perforation through a valve. So the stigmata of those things on echo, in addition to the ventricle won't be dilated, it'll be hyperdynamic and brisk. The atria are unlikely to be dilated. There may be flow reversal in the aorta. They're unlikely to have the raised atrial pressures and things if it's an acute case, and their hemodynamics clinically are going to be worse, maybe.
Chronic? What about chronic?
Sorry, what was that?
What about chronic AR?
So chronically, chronic AR is going to be associated with a dilated aortic root, potentially dilated left ventricle, raised left atrial pressures, and there'll be flow reversal in the aorta. The patient will have, the dilated ventricle, the thin walls, etc.
Don't forget about diastolic MR. I think with the acute, everyone wants to talk about that. So diastolic MR for acute. Easy marks, don't throw that away. Cool. Drew, do you want to crack the next one? Just let it run through and then talk back to us, okay?
Okay, so peristernal long axis, or sorry, I'll just jump into it. So this patient has severe aortic regurgitation centrally and through the right and left coronary cusps. The particular lesion between the coronary cusps might represent a perforation, although I can't appreciate any sort of vegetations on the aortic valve, and a clinical history might be more telling. Otherwise, the mechanism, there is some degeneration of the noted on the leaflet tips.
But if I gave you an LVOT diameter, which is maybe something we could have added into this one, let's say the LVOT diameter is 25 millimeters on transesophageal echo. So we're confident about that measurement. So 25 millimeters.
So I think that would be within normal range.
Up. It's high. So
It'd be
normal
high,
range is
okay.
like 18 to 22, a bit like a VTI.
Sorry, the LVOT, VTI.
LVOT diameter. So the LVOT diameter is 24 to 25 millimeters, so it's quite big.
Okay. So I guess that would be annular dilatation.
And that's why we're seeing that central jet that you can see in that cross section and the severe regurgitation. And I guess what we're missing there, and it's a bit of a subtle finding, maybe, is that normally the coaptation for the aortic valve might be a little bit bigger. This one, it's sort of right out like that, a little bit like, mitral regurg with annular dilation there. So maybe the cusps joining is not quite as big as it normally is, which is why you've got the regurgitation.
Okay, thank you.
Nice, good job. All right. Joe, back to, hand up. Sorry, Joe, I missed that.
Going back to that short axis with the colour, looking at the en-face, I wasn't sure whether there was a second jet or whether it was coming through the leaflet.
I think we're picking up that little, if you look at the short axis, I think we're picking up where the right and the non-coronary cusp are being pulled apart. Because there's not a huge amount of, like, if we pause it just
there, just before that.
I think with the annular dilation, we're seeing that right between the cusps.
Okay, so it's not a perforation then, really. Yeah,
and it wouldn't be that subtle in the exam, I'll be honest. I think I understand the arguments, but it won't be that subtle. Juan, hello, how are you, buddy?
Good, Sam, and you?
I'm very, very well indeed. Can I quickly fill you in on just a couple of things? Sorry, guys, I know we've gone over this twice now. Juan, you're going to be sitting, you're sitting the written and the Viva, aren't you?
Yes.
Sweet. Okay, just a real quick update on something. So the written exam is being reformatted a tiny bit. So ASUM will be in touch and let you know about this, but I wanted to let you know first as well. The written exam, instead of having 10 questions and going through it at sort of 15 minutes a time, there are going to be 9 written questions, and the last question will be a echo, sort of a semi-full study, sort of 20 or 25 slides, and then you've got to write a conclusion on that study. And to do that, we're going to give you 25 minutes. So we're going to get rid of one of the questions. We'll get rid of the reading time. You had 10 minutes of reading time at the beginning, just so you start the exam straight away. You go through your 9 questions and you've got 25 minutes to look at this case and then write a conclusion. So it's a little bit different this year. And other than that, the written exam can be done by typing. So it's going to be typing, not all writing questions. And I think you can choose which one you want to do, but ASUM will contact you and ask you what to do. But I think most people will probably type. Does that sound okay?
That sounds good.
Cool.
So basically, you're reporting an echo, a study, basically.
As one instead of one of the written questions. And I guess I certainly brought this up. I didn't think it was going to come through quite as fast as it has, but they've decided to go with it this year. And I think it's just it's more like real life. It's what you do on a day-to-day basis, probably. And you're just writing the conclusion, not the whole report, just the conclusion. Cool.
Right. I like that.
Cool. Right. We're going through some aortic regurg questions, and in particular what I'm going to ask you to do on this one is tell me the mechanism. So when you see moderate or severe MR, we always talk about going mechanism. It's the same for AR. So when you're seeing it, talking about the aortic regurgitation, then just go straight into why you think it is there. So I stole these from the wonderful magazine Case. So they just kind of they put all the different slides together. So why don't you watch it all the way through once or twice and then give us your conclusions, okay?
Okay, so first of all, the aortic regurgitation appears severe based on the width of the jet relative to the left ventricular outflow tract dimension, AP diameter even. It's almost 100%.
Yes.
It's central, and it looks like there's potentially an independently mobile lesions on 2 of the leaflets.
Which leaflets do you think are affected?
Definitely the right coronary and probably the non-coronary. Yeah, so I would want to see other views as well. I'd like to see the apical view to measure the, I mean, it might be probably not relevant to measure the pressure half-time, just to further assess the severity. And obviously this patient would need a, yeah.
Nice.
So,
what if we're thinking this jet is eccentric, what confounders does that give to some of your standard measures of aortic regurg?
Yeah, so I mean, obviously it might affect the measurements of the width relatively to the left ventricular outflow diameter. It might affect the interrogation angle, the angle of insonation when assessing continuous wave Doppler to assess the pressure half-time.
Very nice.
Yes, the other way I could assess severity is to have a look at the LV, so to see the effects of it. Is it dilated? Is there reduced contractility?
Based on this guy with a history of infective endocarditis, do you think this is acute or chronic?
I think this is acute.
So do you think you're going to get the LV remodeling with acute?
Yeah, no, you're right.
So all that remodeling stuff for the LV, that's all chronic. This very much looks like it's acute to me. And one of the things I'm worried about this is whether we've got some kind of perforation, because we're seeing a bit of a defect on that 2D plane in the it's the parasternal long axis view, is it? Yeah. So maybe the 120-degree view, you can see that there's an obvious 2D defect. So again, as I was saying to the others, when we're talking about severity of regurg, give yourselves a systematic approach. Talk about 2D defects, 2D appearances, acute versus chronic for LV remodeling. We're going to talk about color Doppler and the problems with eccentric jets being that vena contractors, LVOT jet heights are all buggered up. Eccentric jets, as you said, angle of isonation when we're in apical 5-chamber view or deep gastric views is going to be messed up. So all of those are problems. And so just talking about severe pulse wave, hollow diastolic flow reversal, descending aortas, end diastolic numbers greater than 20. We might just in the meantime time flick on. So here we got a guy with a history of cabbage, murmur, shortness of breath. Again, rip-roaring, eccentric AR, and that's probably becoming from some sort of valve prolapse. We can see that one of the, sorry, I'll try and do it's like that in that short axis view. So you've got a bit of a prolapse. We're still getting that marker pointing up towards the aorta. So I think that's giving you that eccentric jet. And again, the standard chat's going to be, talking about confounders with usual things. So just have answers for that. But again, giving that mechanism, if you can see something, if you see a hole, you see a prolapse, or you see restriction like this one, just bring that to the attention of the examiner and just take them there straight away. I think we love talking about acute versus chronic. So chronic's all LV remodeling, hypertrophy, raised left ventricular end diastolic pressures. Acute's all about hyperdynamic, LVs, diastolic MR, eccentric, weird-looking jets. It's always something horrific, and the valve always needs being sorted out if it's severe. Cool. Any final questions on that? So just again, the summary slide, just talking about all the different kind of mechanisms from this great article that was written, and mechanism for AR as well as MR. Right, we're back to Joe. Have a go at this one. So 25-year-old history of ANCA vasculitis, pulmonary hemorrhage, gastritis, and hypertension, intermittent pleuritic chest pain and palpitations.
So is it going to flick through a few different, or is it just one?
No, I think this is just one. Why don't you just have a look at that one first of all, and then I'm going to show you this one. Yeah, let's just look at this one. That's even better.
So it's apical 4-chamber view with a bubble study. And the most obvious thing is an ASD, which is, or defects between the left atrium and the right atrium. And it's going from left to right because there's no bubbles crossing the other way. So that would indicate that the left atrial pressure is higher than the right atrial pressure. and it's crossing across into the right atrium. So it could be an ASD, for example, or going from the history, it's got vasculitis. So
yeah, I think you're good. You're good.
Some generation, yeah. So now we have a toe image, which is the bicaval view.
Which side do you expect the superior vena cava?
On the right. And you can see quite clearly the intraatrial septum is bowing into the right.
How would you differentiate the intraatrial septum from a Chiari complex?
The Chiari complex, I think, would be on the other wall.
Nice.
And also if there's that other thing, I can't remember the name
Hang
now.
on the other wall. Sorry, what other wall do you mean? Sorry, where is it?
So the
right side,
the right wall, the right-sided.
Yeah, what is it attached to?
It
is the right wall, but you got a big area on that right wall.
Yeah, closer to the IVC
yeah,
entrance.
very good, very good. It's like a little valve for the IVC.
Yeah. And then there's the other structure on this on the SVC side, which I can't remember the name of it at the moment.
So it's the eustachian ridge. Is that what you mean?
Yeah, the eustachian ridge.
Yeah, that's on the other side as well. So the eustachian ridge is attached to the sort of the inferior wall there. And what's the difference between a Chiari complex and an eustachian ridge?
It's all based on embryology.
Yes.
I'm
not gonna let you get away with that either.
I don't know.
It's all based on embryology. That's the best question. It's the best answer. So remember, the eustachian ridge is just a solid wall that helps direct that blood over onto the patent foramen ovale when you're a baby, so that you can get fluid in there. And it looks like a sort of fixed, sort of almost like a finger that's sitting against the RA wall. And then you've got the Chiari complex that's like a big old spider web. And so you may be talking about the differentiation, and I think the bubble study is the big differentiation, because the bubble study clearly this shows that there was no crossover, but the Chiari complex is just like a web of, whatever. It's just like a spider's web. So lots of things could go through that. So the bubble study will be able to tell you the difference. And this has got much more of a linear structure, but similar kind of chaotic motion. Very nice. So there's the bubble study. Beautiful.
Is there some color through that so you can sit? Can you see?
No. But you did very well. Right. Joe, were you here last week?
I wasn't, no.
Brilliant. So you can answer me this question. Discuss the types of ASD from most common to least common and tell me their associated features.
So there's primum and secundum's the most
common first, please. So you're saying that the primum is the most common?
No, secundum is the most common, followed by primum. Yep. And there's about 5 different types based on whether they're membranous and where they are within the...
It's not membranous, there's the VSDs.
There's the VSDs.
We love asking this question for some reason, for such an unfortunately uncommon scenario. So
I know it's based on where they are within the atrial wall, and based on whether it's overlapping.
Cool. So we'll just go through. Let's move on to chat. You can pass on to chat or Juan. You can choose either one.
Go on, chat.
Yeah, there we go. So chat, you got this question. Discuss the types of...
Joe, I was shaking my head. I don't know. So the honest answer is I haven't read this recently and I can't remember.
Well, do it today. So it's nice and easy. I'm going to show it to you. Juan, do you know before I give you all the before we go through
before we move on, that bubble study?
Yeah.
And the toe, like on the toe, it looks like an aneurysmal interatrial septum, and on the bubble study, you don't really...
Yeah, I agree, and that's it's a little bit esoteric. And if we were ever going to give you something like this in an exam, it would be probably a little bit more obvious, or we wouldn't expect, some of the gentle natures. There is a bubble or two coming across. I think an aneurysmal intraatrial septum does not have a bloody great gap sitting there, which is the atrial secundum. So it's
Okay.
that gap across the base there, which makes me think that this is a secundum, albeit with an aneurysmal membrane attached to it.
Okay.
So let's just talk about the types of ASD, and perhaps
I know the third type of.
Yeah, go on, tell me. Oh, sorry, you're on mute there, buddy.
Sorry. Secundum most common, primum second most common, third most common is sinus venosus, and the fourth one, no, there's two types of sinus venosus, and there's an unroofed coronary sinus, which could be sometimes classified as an ASD.
Fantastic. Perhaps we might be able to persuade. So if anyone's got any difficulty trying to remember any of these, perhaps we might be able to ask Emma to do her not interpreted dance. Emma's going to do her maybe we could do the plasticine one. We can record that someday. So she's got this most amazing talk where she uses plasticine to try and explain all the different kinds of ASD. And I'll be honest, as soon as I thought I knew it, and then I watched her do it with the plasticine, and I understood it, and you don't forget it after that. But just so we'll do that maybe another time. But at the moment, let's just go through all the different types here. So secundum is the B. That's the one that we were just seeing in that one. That's the most common one. Big old holes right in the middle of the ASD, and we're looking from the right atrium towards the left atrium here. Next one that you've got down here is D, is going to be the primum, which where the sort of holes sort of open up right down there, and that's associated because it's right next door to the mitral valve with that cushion defects or something they call it. So you get weird mitral valve pathologies and dissociation between aorta and between the atria and the ventricles somehow. The other two are pretty uncommon. So that's the sinus venosus or the inferior vena cava, the inferior sinus venosus in there. And those are at the back and the top of the wall. And so that means they're associated with the pulmonary veins. So particularly you get these anomalous pulmonary veins inserting in the back there. And then the last one that's super weird I haven't seen before is the coronary sinus. I've maybe seen once, an unroofed coronary sinus. And I find all of these really bloody hard to try and pick up, other than the primum and secundum on toe. But you just got to be really careful. The ones that we've found recently, actually through our echo lab, and there was just some really good tips and tricks, if I may suggest this while we're doing that. First of all, if you've got what we might show you in the exam, which I think is really relevant for the critically ill, if you've got unexplained right ventricle dilation in young people, you've got to go searching for ASDs and go looking for that. Okay, so unexplained right ventricle dilation. If you've got unexplained atrial dilations in particular, unexplained differences in QP/QS, then we've also got to be thinking about ventricular septal defects. So one of the things that Faraz, the co-head of the echo lab here, if you haven't met him, I'll try and get him on a couple of times because he's unreal at echo and imaging, is that he, on every single echo he has, he says, you've got to look at your RV VTI as well as your LV VTI, the RVOT VTI and the LVOT VTI. And if you've got the RVOT VTI greater than your LVOT VTI, you've got to explain it. And it's got to be explained by some sort of shunt, and normally that's some kind of ASD. So yeah, if the RVOT VTI is larger than the LVOT VTI, do a toe, go looking for weird ASDs. And for me, I'm going to ask for help when I'm in that situation, because I find the superior vena cava ASDs and IVCSDs and the coronary sinus particularly hard to try and find. Cool. Nice. Let's move on. I can't remember what this one is. Where are we up to? Juan, do you want to have a go at this?
Okay.
Oh, this is unbelievable. Okay, this is not something we can't in the exam. This is but it's an unreal case. And what I want you to do is just try and, so this is all about, I just need you to explain it. I don't need to give me a diagnosis because that's impossible, to be honest, but just tell me what you're seeing in a nice, clear, articulate manner.
I'm seeing is it a subcostal view, or a short axis subcostal view?
No, I think this is just this is a parasternal short axis view.
Sorry, parasternal short axis view at the sort of between the mitral and the mid-pat level. It's not quite full. The major abnormality, the most significant abnormality is that there seems to be some sort of pericardial abnormality. You know, there's probably a sort of trace pleural effusion, but also posteriorly there's seems to be heterogeneous material within the pericardium.
Nice. Yeah. So you said that there was something abnormal about the pericardium. If I can just persuade that, you know, the bright line here is the pericardium, right? So if it's not something outside the pericardium, what do you think? Talk to me about what's inside.
Then it could be infiltration of the myocardium, an infiltrative disease. And I guess maybe that's why the strain, the global longitudinal strain has been shown.
Yeah, super light. I mean, you got lots of blue and pale red.
Yeah.
Yeah, good job. Let's show it to you with color Doppler. So give me a differential for that mass that is sitting there in the right ventricle. So what's a differential for a cardiac mass in this situation?
For a cardiac mass would be tumor, either a primary malignancy or a metastatic malignancy. It would be a thrombus. It would be an artifact. But I guess in this case, it'd be some sort of infiltrative disease. Is it?
What else? So again, we love asking about cardiac masses, and we expect you to give us a differential and talk about, and, you know, obviously go from most common to least common. So I'm going to let you say tumor first for this. But I'm actually maybe not, because we're sitting in the RV with a reduced LV function. I think thrombus should come first.
Okay.
So it depends on what we're looking at, right? If I was to give you, you know, if you're just seeing something flicking around in the RA, I expect you to say normal anatomical variants, lines come first, or artifacts potentially. You know, those are probably the most common masses that we see on echo. So don't forget those, particularly in written questions, or when we're asking it to you, tell me the most common things first, which is always artifacts, us sticking stuff in the heart, like lines, or normal anatomical variants, eustachian ridges, Chiari complex, stuff like that. Then it's thrombus and infection, or infection or thrombus and infection, right? Because those are always much more, the most common pathology are always those. After that, we've got tumors. And tell me again what you said about tumors. Which is the most common out of the cardiac tumors, primary or secondary?
Secondary and metastatic.
Yeah, nice. Metastatic. What metastatic ones come into the heart?
Lung, renal.
Good man. Good man.
Yeah.
Cool. So what we're looking at here, I mean, maybe just in the meaning of time, we'll just flick through this, but I just want to show this case because it just blew me away. So if you were to explain this, we'll obviously talk about smooth-walled, heterogeneous masses that are sitting there. It looks like in the right ventricle, infiltrating the wall of the left ventricle with smooth surface, and it looks like a cyst, blood, different fluid densities. That kind of discussion would need to be had. But this guy was like, he'd been traveling, and this one had been traveling. Just watch this video. It's so cool.
Oh.
Yeah, just a little one. Wait till the next one comes out. And this is why this is the best journal in the whole world. Isn't that horrific? That's being pulled out of the right ventricle.
Wow.
I know, right? What is that? That's like alien-esque. Oh, it's revolting.
What is it?
So that was echinococosis, which is a parasitic tapeworm that this guy picked up. Had been traveling in, I think, had been traveling in South America, eating weird pork and stuff like that.
If you'd given me enough time, that would have been my next differential.
Nice job. Right, who is next? Where's all my? Let's do this one. We're in Viva Practice. We'll do 5 or 4. I can't remember what we're on. But let's go play. Can you see that? No, sorry, let me share the screen. You cool with that? You can see that one? Cool. Who's I thought it was chat next. So she just left the room. That's cheating.
Here she is. She's
Oh,
back.
there she is. All right, chat. Point and shoot questions. Ready?
Mm-hmm.
Hang on, Ben. Sorry, hang on. Ben hasn't done them. Oh, sorry. I got Ben here as well.
I don't want to cut in line.
No. You're right. This is you're doing the exam. We gotta. Let me just unblur my background. So all right, point and shoot questions. So you will get one of these in the Viva. We like these as well. They're sort of normally towards the beginning of the exam, so just to warm people up. And again, it's sort of about 45 seconds to a minute per slide.
So transesophageal, I've got a gate in the left atrial appendage, and I've got variable outflow velocities or greater than 0.4 in CCD. Hang on, no. Do I get any history of these things? No.
No.
Okay.
Sometimes, but
Okay.
not in this case.
Yeah, so it looks like a transesophageal echo with a pulse wave gate sitting in the left atrial appendage.
Or
it could be in
is that a normal looking left atrial appendage flows?
No, it's not. These.
So what is it then?
So it's a pulmonary vein.
There we go.
Yeah.
Excellent. And what are you seeing?
I am seeing flow away from the probe in systolic flow reversal. Where they go? Yeah.
Systolic flow reversal and
in the
systolic,
pulmonary.
yeah, systolic flow
So
reversal, yeah.
that can be severe mitral regurgitation, or
it is severe mitral regurgitation, right?
yeah.
So left
What did I say?
left atrial pressure elevation doesn't give you systolic flow reversal. It just
No,
dampens down.
down. Yeah.
So this is likely secondary to severe mitral
mitral
regurgitation. Yeah. These are all different patients, right?
Oh, yeah, cool. Okay. So I'm going to get close because the screen's small. So I've got a RVOT VTI up in the top right, and I've got, is this the same measure? Sorry,
Yep.
It is, isn't it? Okay, so RVOT VTI or pulse wave gate in the RVOT outflow tract. There is some mid-systolic notching on the outflow tract trace. It's consistent with raised pulmonary vascular resistance, and the VTI itself is, where's the number? 21. Okay, so that's elevated. This is suggestive of raised pulmonary vascular pressures.
Nice. You said it's indicative, the flying W sign was indicative of
It's a
pulmonary
raised
vascular
pulmonary vascular
resistance.
resistance.
I'd say that probably more pulmonary, the systolic flow notching is associated with pre-capillary pulmonary hypertension. The pulmonary acceleration time is classically associated with pulmonary vascular resistance. I don't think it would probably be that pernickety, but just resistance is different from pressure.
Yeah.
But do you guys remember the difference between, if we talk about pulmonary hypertension, you always go left-sided heart problems causing raised pulmonary pressures, or so that's post-capillary or pre-capillaries on the other side, particularly flying W sign, pre-capillary, all to do with, whatever, CTEF or whatever, and us with ventilation, all that kind of stuff. Cool.
Yeah, transesophageal echo. And I'm looking at the interatrial septum. On the color flow Doppler screen, there's color flow across the septum concerning for interatrial shunt. I'd need to slow it down to appreciate which way it's going. I'd expect it to go from left to right due to left greater than right pressures. There's bubbles administered in the bicable view down the bottom. I'm not sure if the patient's valsalvating or coughing, but I can't see any bubbles appearing in the cycles that I've got there, suggesting left to right shunt rather than right to left.
What do you expect with a left to right shunt on a bubble study?
You can get what they call negative contrast. So portal vein.
Critically appraise this image.
Okay. So the image itself is a portal vein Doppler profile. Yeah, there's 2 gates. 3 gates, 1 gate, sorry. Portal vein Doppler profile. There are many ways that I can improve this image. So I need to change the scale so that the spectral profile takes up at least 2/3 of the screen. I'd like to only have 3 cardiac cycles rather than 4 or 5. And whilst this does not appear to hold the normal spectral profile of an actual hepatic vein.
Yes, hepatic vein or portal vein?
It's a portal vein profile.
I think it's an hepatic vein.
Is
because it's coming out of the IVC.
Yeah, but anatomically, yes,
fantastic. So this one might be. So what are these called? So hang on, what are these artifacts called? You said there are 3 gates.
Yeah,
and ghosts. You want to ghosting artifacts, right? So what are those caused by?
So they're caused by the pulse repetition frequency being off. I can't remember the details.
Being off.
Yeah.
Tell me, what do you want to say? Is it too high or too low?
It's too high.
Too low.
Too low.
So pulse repetition frequency is too low. You need it to be higher.
To get rid of
and
it.
you're going to do that by, so you can increase your pulse repetition frequency,
Yep.
or you can reduce your scale.
Yeah.
Or reduce your depth.
Yep.
Or change to continuous wave Doppler.
And then there's also another filter you can put, isn't there? Isn't there?
Oh, you can change the frequency of your probe. So you can reduce
there
the
was another way.
frequency.
Okay,
Yeah.
There was a
Change
high repetition frequency or something.
Yeah.
So you could do.
Pulse repetition frequency. Yeah.
Yeah. Okay.
Cool.
Yeah.
All right. Nice one. I forgot where we're up to. Drew, do you want to have a go or something? Do you want to have a go?
Yes, please.
Cool. It's a 49-year-old male, left upper quadrant abdo pain for 3 days, mitral valve surgery 20 years ago, AF, hyperlipidemia, hypertension, recently stopped all medication, including warfarin. So what do you think you're going to see?
Upper quadrant pain, valve surgery, stopped his medication. So like a thrombotic sort of process.
Absolutely spot on. So, I mean, it's not always going to be absolutely perfect, but you know, you can you do it. So what type of valve are we looking at? And describe this picture.
The type of valve would be the mitral valve. This is a peristernal long axis 2-day picture, zoomed out.
Definitely not getting away with just saying it's a mitral valve. You've got to tell me more than that. So you know that's not what I'm asking. So what kind of valve is the artificial mitral valve?
Oh, yeah, sorry. This is a mechanical mitral valve.
Very good.
The key finding within the left atrium is a erogenous mass within the left atrium, which I'd want to look at various views to confirm that this was a possible mass, or if it was an artifact, or if it was a line, or a tumor, or in fact, like a vegetation. Other features, looking at the left ventricle, the left ventricular function appears reduced. The aortic valve appears normal in this particular view. The right ventricular outflow tract appears normal size.
Yeah, okay, nice. I think with the discussion, it's excellent. You're going through to the money straight away, and you talk about that mechanical mitral valve. Did you tell me that the left atrium was the size of a house? So you're severely dilated left atrium. And I think that's homogeneous, smooth surfaced mass with independent motion sitting in the left atrium. Given the clinical history, that's highly suggestive for a thrombus. Differential diagnosis may include infection or a tumor, in particularly a what? What kind of tumor?
A tumor like an atrial myxoma.
Yeah, very nice. That's a smooth-walled, a smooth surface thing in the left atrium in particular. So you told me that the left ventricle function was down. Again, I think I need more than that when we're at the DDU level. So
appears severely reduced and
there we go.
dyskinetic.
Fantastic. So, and it's got dyskinetic motion, severely reduced akinetic features. You could probably even say there's some regional wall motion in there. And then the aortic valve appears normal. RVOT, I'd say, is not normal. I think that's showing that there's reduced RV function. Kicking in something like, I am extremely worried about this patient, that always goes a good long way, right? Because that's just showing you putting that sort of clinical stuff with your echo findings, being a doctor, being a nice human being, all that kind of stuff. You know, the examiners love that.
So this is a transesophageal echocardiogram. This is a bicommissural view. I guess the key feature is a smooth-walled, mobile structure, large mobile structure within the left atrium with spontaneous contrast. Other key features are his mechanical valve and artifact related to that.
The artifacts, what causes the artifacts you see there? What kind are they?
I think this is a sorry, I can't recall.
Yeah, I think it's nice. So we got shadowing and reverberation. Yeah, so you got the
reverberation
ones there from the what do you call it, the rim, and then you've got the reverberation artifacts from the the valve movements. I think that we've got a bi-tilting disc is a nice way of describing these ones as well. And obviously that's what we look at to try and figure out if there's any kind of thrombosis that's actually blocking up the valve. And yeah, you got the sec, you've got obviously the smooth-walled mass. And again, I just think the ventricle function was the last thing we could have talked about. That's all lovely. Last one. Where are we up to? Who's next? Was it Joe? Are we back to Joe?
Yeah, I think so.
Nice one. Okay, so 49-year-old female, short of breath, chest pain and back pain. She's a refugee, no past medical history, a borderline SATs, serial troponins negative, an ECG is suggestive of minor lateral ST depression, and a chest X-ray showing minor pulmonary edema. What do you think we're going to show you here?
I'm thinking about aorta.
Yep.
Rheumatic heart disease.
Nice. Why am I telling you aorta if it's a refugee? Yeah. So just think I'm telling you all of these things for a reason, I think. So refugee. So yeah, we might not have any past medical history because she hasn't seen lots of doctors. SATs borderline means that there's fluid in the lungs, right? It's not going to be a pneumonia because you're in an echo exam. Serial troponins negative, so probably the LV's not going to be a major problem. ECG, minor lateral ST depression, maybe there might be some regional wall, keep an eye on that. Chest X-ray, minor pulmonary edema. So I'm thinking LV, I'm thinking valve problems, refugee, think rheumatic fever, I'm thinking mitral stenosis, right? Could be wrong. It's going to be something wrong with the LV on that side of the heart, raised left atrial pressures. Are you going to show me diastolic stuff? So, cool.
Parasternal long axis. The most obvious feature is the mitral valve abnormality on this 2D with a hockey-shaped appearance of the anterior mitral valve leaflet. And the posterior mitral valve leaflet is also extremely thickened with reduced movement, so it's restricted. The LA is dilated, which suggests chronicity. And in terms of the LV function, the walls, the anterolateral and anteroseptal and posterolateral wards or infralateral wards are thickening and contracting. So from this view, the function looks normal. The aortic valve is thin and collapsing well, so it's not affecting the aortic valve at the moment, and the RV function is normal in this view.
Andrew, that's really nice. That's perfect. Great job. I was going to say maybe we got a bit of thickening of that RV3 wall, again, suggesting chronicity. Maybe got some pulmonary hypertension coming around.
This is the colour flow over the mitral valve, and there is mitral regurg with an eccentric jet posteriorly, which fits with the hockey stick feature of the anterior mitral valve leaflet. So it's poorly coapting. And this would suggest severe mitral regurg because there is quite a large jet. I can see quite a lot of, I can see some flow convergence, but there's a lot of acceleration within the LV. So I'd need to see a few views for that first.
Let's go to that one.
Okay, so this is the continuous wave through the mitral valve from the apical 4, and it's looking at the mitral valve area, so it's tracing around the mitral valve to get a VTI and a gradient to look at the mitral stenosis. And the mean gradient in the left picture is above 10, which is severe, and then in the deceleration time on the right picture, the pressure half time is also prolonged. I think it's supposed, I can't quite remember the value now. I think it's 200.
220.
As severe. So this to me is indicating severe mitral stenosis.
Any confounders to that?
Yes, so we know we've got an eccentric jet. So the alignment with the colour flow, with the continuous wave Doppler may not be accurate. So you may actually
anything else?
This.
Mean gradient of 10.5. So you said over 10 is severe. Any confounders to that?
It's based on the LV function as well, and the LA pressure. So it's the pressure difference between the LA and the LV.
Why is LA pressure difference? Yeah, take me more.
So if you've got high LA pressure, then the gradient between the LA and the LV is going to be small, which will mean that your color flow, your continuous wave Doppler gradient will be narrower. So then,
so it could be lower, right?
Lower.
What about this? What's the regurg? You were talking about a lot of regurg that comes through. So just like with aortic regurg, where you can overestimate the severity of mitral stenosis, maybe if you've got that kind of mixed valvular pathology, the same could be the case for this. So just be worried about the mean gradient 10.5 may overestimate the severity of the mitral stenosis.
Yeah.
So again, trying to put it all together in terms of 2D features, symptomatology, along with the continuous wave traces, and using your area pressure halftime, we may be able to get away with doing some form of, if you could get the measurements correctly, you can use the continuity equation.
Yeah.
Valve area on toe. Yeah. Let's leave it at that for the day. It's 3 o'clock. Any questions? Everyone happy?
Yeah, thanks, Sam.
Pleasure. Well,
Thank you very much,
studying.
Sam.
Hope it goes well. No problem.
Thank you.
So chat's going to go away and look up ASDs.
So am I.
And then just keeping going on those valve, those little valve summary statements, taking 45 seconds to go through each of your TR, AR, MR, AS, MS, and we'll go from there.
Yeah, brilliant.
Hey guys, take it easy.
Thanks,
Thanks,
guys.
Sam.
Bye, everybody.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @Nepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.